Hello everyone, Kirk Warner here, and I'm joined today by my personal physical therapist, Charlie Merrill. Charlie is a manual physical therapist. How long have you been practicing?
Almost 20 years.
Woo! Today it's going to be a little bit different of a video. I'm going to be kind of showing you what it looks like from the patient and practitioner perspective to go in for a physical therapy appointment for some sort of nagging injury. I personally have a little bit of a knee thing going on. I don't know if you guys have noticed the trend of the videos that I've been putting out lately. It's usually been around knee pain. But this is part of my process. And I wanted to kind of take the opportunity to show you guys a little inside scoop into what we're going to be doing in terms of inside of a practice. And if you take anything from this video, it's going to be some things that you might be able to implement on your own. If you work with a physical therapist, you can bring some of the things you learn in this video up with them as well. This is kind of more of a learning video than anything that
problem solving.
Yeah, then you see where you're like, here's this problem, here's this solution. It's a little bit more of a look into it. So the first thing we're going to do is evaluate. Cool. Evaluating is kind of the first step, so let's begin there.
So we're talking about Kirk's knee today, and the first thing I do is get a subjective history, which is basically his story about when his discomfort started and how it's behaved since then. So Kirk, tell us a little bit about going back to when you first noticed this. What's the story?
First time I noticed it was in it was in Malibu. I went down to a race and I flew out there, and then I was crewing and aiding and filming a friend at his race, and I left something like a half mile away from where I was, so I ran down to get it. And that's when that was the first time I remember feeling.
So you hadn't even run that much yet. It wasn't like you traveled a bit, hadn't warmed up yet, and then kind of raced to get this thing from the car.
Exactly.
But were you there to crew an ultra?
I was there, yeah, to crew an ultra.
And you were planning to run a block?
Nope.
Oh, you
I
were
was just there
okay.
crewing.
Okay.
Wasn't pacing.
Okay. So so that's when you noticed it. Where was the pain at that point? Where did you first feel it?
It felt like lateral and deep.
Like inside the joint?
That's still kind of what it feels like. Yeah.
Okay. Did it catch? Did it lock? Did it
It feels a little catchy.
A little catchy.
Yeah.
Okay. And still feels that way.
Yeah.
Okay.
It feels kind of like a pressure. It's something will happen and then it'll kind of generally get a little tighter, and then it just kind of is deep and pinchy.
Okay. What are the things that aggravate it when you say something will happen? What are the aggravators, the triggers at this point?
Running flat on flat ground at a tempo pace.
Okay.
I can run pretty slowly and not have it happen. I can run up a hill and not have it happen. I can run down a steep trail
Downhill.
for a long time.
And it's okay.
Down steps and stuff, and it's okay. It's flat ground.
What about running really fast?
Haven't tried it.
Okay. So slow is okay, and up and down terrain is okay.
Yeah.
But you haven't tried to push it that way.
Yep.
And so do you notice the symptoms when you run, or is it more present after you run, or both?
Happens midway through a run, and then it doesn't really bother me the rest of the day. For the most part, it's a little tight, but it's not
more during
the run.
When
I'm running. No. Yeah.
Okay. So it's not like you after you sit for an hour, you get up and you're super stiff because you ran that day.
That's right.
So you can kind of get the sense that I'm asking him a lot of questions to try to get a sense for maybe what tissue is injured, where he is in the healing process before we go into the evaluation. So I have a little bit of a head start. I don't have to end up looking at everything to help him problem solve. So a lot of the problem solving happens in the first 10 or 15 minutes when we're just having this conversation. So remind me the date again.
That would have been
approximate
early February.
Okay. So it's been almost 2 months.
Almost.
At this point. Has the pain behavior changed at all since then?
It's gotten better.
It's improved? Improving?
Yeah, the amount of distance I can cover before it happens has increased. And it got better when I pushed it harder.
Okay.
So
Good sign.
Yeah. I like haven't been able to run more than like 10 or so miles a week, which is like nothing. And then last week was Hell Week for my running group, which is where we do all the peaks, and it ends up being like 30 something miles, and I was able to do it for the most part pain-free.
Okay.
Because I was out there every day.
Interesting.
But it was also steep for the most
hilly
part.
terrain, which you said was actually better for you.
Yeah.
So this is a good point, because a lot of us, when we have pain, the first thing we do is we shut everything down. And my experience is that a lot of people actually get worse when they do that instead of better. Find it's much better to either change the context or find a way you can do that thing without pain. Kirk's saying that he has situations where he can do okay. He's just avoiding tempo runs on flat ground right now.
Yeah.
You can also cross train. The last thing you want to do is shut everything down, lose all your fitness, stiffen up, and then end up in a worse off situation. So good on you for taking that approach. I presume you've also been doing some corrective exercise because you're smart and you have a lot of tools at your disposal, and that stuff has been helping.
I think so. It's kind of tough to tell because there's a lot of different variables happening at once, but I've been working on my hamstrings. My lower quads seem to be just tight.
Hamstring strength.
Yeah. Strength.
Quad mobility.
Quad tissue mobility. And then that's kind of the two main focuses.
Okay, cool. Medical history. This is an important part, is knowing if you've had knee pain in the past or if there's anything else that might make the picture more complex.
No.
You've had some overuse stuff, haven't you, in the past?
I've had plantar fasciitis.
Is it on the same side?
It was on the other side. So
that was on the left, the knee pain is on the right. Okay. Any other overuse injuries? Or?
I have herniated low back in my L5S1, but that hasn't caused me any pain in the last couple of years. So
okay.
Yeah.
And you had symptoms from that, but that's pretty much completely cleared up. Yeah. So you notice it's really helpful sometimes to normalize these past injuries. A herniated disc is something that is very common, and most people do just fine, are asymptomatic, and can even run like Kirk really well with past injuries. So thanks for sharing that. Anything else that comes up for you that feels significant or related or connected in any way?
If I really have like a hard-working day and the knee gets pissed, my hip flexor will also light up.
Okay.
Like it'll
that happens just first, and then this happens
and
second.
Then secondary tightness. Up. Yeah.
Moves upstream.
Yeah.
Okay.
It hasn't happened that much. It's not every time, but like if I have like a really bad day, like I had one run where I went out way too early and ran like 8 miles, and but it was a loop. And it happened when I was like at mile 4. So I like had to run another 4 miles to get home.
I see.
So I basically like hobbled for 4 miles. And then that night, like I was just sitting in a chair, and it just like, I got up and it felt like there was a tourniquet around my hip flexor. Yeah. So I was just like, whoa.
Probably because you were running differently and you changed your biomechanics to make it home, hobble home, as you say.
Yeah.
Okay. Exactly. You're not taking any medicine right now. And I know what you do for a living.
Yeah.
You're very active. You're on your feet a lot. You're not inactive. You don't travel a ton. So I can sort of rule those variables out. Is there any other recreation that you're doing right now in addition to running?
Ski mountaineering.
Ski mountaineering. Okay. Does that bother your knee?
Not at all.
Not at all.
I was like, in the heat of this thing bothering me when I was running, I was able to do like a 9-hour race with no problems.
Okay, when this was at its worst,
yeah,
you could still skimo. Okay. And ski mountaineering.
Ski mountaineering
is basically racing on lightweight equipment up and down hills.
Race up the hill on skis, race down the hill on skis.
For time.
Yeah.
And so the impact, presumably, as I'm problem solving through this, the impact is going to be less. However, the terrain can be off camber. There are a lot of hills. There's a lot of muscle fatigue. And so you start to look at that and say, that's curious. I wonder why you can do so much work with this knee in that context, but then when you're running, the context is different. So we're going to sort of problem solve through that when we get to the physical examination. So I don't have any other questions unless you have any other tidbits you want to add in there.
Nope. Seems
Okay.
like it's impact driven. Like
Okay.
the fact that I can ski for hours and hours and hours, but like can't run for more than 20 minutes, just that like compression
The impact.
might be something that just like lights that
And
up.
the one thing we didn't talk about was you're a midfoot striker naturally, and your shoes that you run in. I forgot to ask you about your shoes.
A bunch of different ones, but my main one is a La Sportiva Bushido.
Bushido. So a stiffer shoe.
Stiff kind of mountain shoe that has, I think, 5 or 6 mils of drop.
Yeah.
Like it's like 4 to 6.
So the heel is only about 4 to 6 millimeters higher than the midfoot, which is somewhere in between a totally flat minimalist shoe and an old school sort of traditional
great shoe,
the Bushido.
I do also play around in Nike Kygers, which are a little more like cushy,
more flexible
like
for
flexy,
sure.
and then a Hoka Speed Goat.
Does it matter what shoe you wear?
Doesn't seem so.
Okay. Yeah, that's also an interesting bit of information when the shoe, shoes can get worn and some people have pain because their shoes are worn, but when the shoes doesn't seem to make a difference, I sort of like put that off to the side as I'm problem solving these things. But if your shoes are getting worn, oftentimes I'll recommend if you're at 300, 400, 500 miles into a pair of shoes, I usually recommend people replace the shoes just because it eliminates that variable from the problem list.
Yeah, I'm due.
We can move on. So there's your first bit of advice.
Okay.
So if there's nothing else you want to add, let's dive into the physical exam.
Yes.
So I generally start my evaluations by watching people move so I can get a sense for how coordinated they are, how their movement quality is, and if I pick anything up early on, it allows me to filter my exam in one direction or another. So why don't we start, Kirk, with you standing with your feet about shoulder width and just bend forward, touch your toes. Let me just watch you bend forward. A lot of runners tend to have a lot of hamstring shortness. Kirk is one of the rare exceptions to this rule. There's something about having tight hamstrings that can be really helpful to help people run fast, but Kirk seems to be able to run fast despite his flexible hamstrings. Does that bother you at all in your back, knees?
No.
Where are you feeling that the most?
Behind my knees.
Behind the knees on both sides. Okay, come on back up. Bend backward as far as you can, like a gymnast. Any discomfort in your back?
No.
Or in the front of your hips doing that?
No.
Okay, come on back up. Let me see you rotate one way as far as you can turn. And then rotate the other way as far as you can turn. So I'm looking at symmetry. He rotates a little further to the right than he does. Come back to the left again. Then he does to the left. So when I get him on the table, I'll look at that a little bit more. Can you show me a 2-leg squat? Your best CrossFit imitation? Just an air squat. Come on back up. So there are a lot of things I'm looking for in a squat. It's very predictive of injury risk, and it shows me a lot with regard to his mobility and his stability from his shoulders and his spine through his hips, knees, and even down into his feet. Do a few more nice and slow for me, Kirk. So Kirk's obviously, as a CrossFit coach, has a relatively good squat, very nice movement pattern. If I'm critical of anything, I'm looking at his low back and I'm looking to see if he can maintain his neutral lumbar position as he gets to the bottom of his squat, which is something we've worked on in the past, right?
Yep.
And it's very subtle, and generally if you're really intentional about it, you can clean it up, and if you get warmed up, you can clean it up. But otherwise, I don't see any concerns there. That doesn't hurt your knee at all. Full depth all the way to the bottom. So already knowing that, I rule out a lot of scary stuff, which is really nice. Yeah. Let me see you stand on your right foot and balance. I'm looking for a couple things here. Number one, I'm looking at his ability to maintain stability on one foot. Running is a one-legged sport, as we've said in the past. You're either on one leg or you're in the air jumping to the other leg. So it's very important that the single leg function is really sound. If you're all over the place, then that's going to show up in your running. And at mile 4 or 6, you're going to start to break down and you're going to get tired and things are going to hurt. So, but your stability is good. Show me a couple single leg squats with the other leg kind of like behind, as if you were running.
Like as far as I can go?
No, just kind of go halfway down. You know, runners don't go that deep. Even trail runners, won't go much deeper than that. So again, looking at what his foot's doing, how much is he pronating, looking at his knee to see if it's deviating inward especially, or if he can keep it stabilized out. I'm also looking to see what his hips do and what his upper body does. Generally, I want his upper body to be vertical. I don't want him leaning toward the side he's standing on. We've talked about this in the past too, Kirk, in past videos. what I'm seeing here is his pelvis. If he puts his hand on his pelvis, or if I do, as he goes down to a squat, if he's not thinking about it, this side wants to kind of drop away a little bit. Do it again. Come on back up. Don't think about it too much. Just go down. As he gets deeper, this left side wants to sort of drop away because this is the unsupported side of his body. And it's very subtle, but I'm looking for subtle things right now because I know that he doesn't flare up until later in his run. So I'm looking for little nuances, right?
Cool.
Try the other side. See if it looks any different. He's got a nice straight foot. His knee tracks really well. He's got pretty good balance. His upper body's staying real vertical. And again, if anything, I'm seeing this side, this right side, the unsupported side, wanting to drop away just a touch as he's going down to the bottom of his squat. But, I'm kind of being nitpicky. I'm just being a little hard on you.
Good.
Okay, so between those 3 tests, I have a feel for sort of generally how you're functioning, even though I haven't seen you run yet. So let's get you on the table, and let's see what we find on the table.
Cool.
To start the physical exam, I'm going to look at a few points of mobility for Kirk. First thing I want you to do, Kirk, is to scoot to the end of the table, and I want you to grab behind one knee. It's called the Thomas test, and as you lie back, if you can keep this knee up there for me, I'm going to make sure your low back isn't too flat. I took some of the space away, and you just kind of keep it there. What I'm looking for in this leg is a couple of things. I'm looking to see how far his hip can extend past the parallel with the table. And he's got really nice flexibility there, which means his hip is pretty flexible. I'm also looking at how much his knee naturally bends, which tells me how flexible his long quad is. This is a muscle called rectus femoris, which can get relatively short in runners because it's important, especially for the swing phase of running. He's not looking too tight there. I'm also third looking for the length of his IT band and the muscle at the top called the TFL, which controls the tension. What I can see here is that his leg wants to spring out to the outside, so I have to kind of give it a push to get it to come to midline, which is where it would function when he was running, in this case at toe off. As I let go, it springs back to the outside. So that tells me his TFL muscle up here is a little short. His IT band, as a result, might have some extra tension coming down through it to his knee. But we know this is not the painful side. So let's switch. Lie back on your back. I'm going to check his back again, make sure there's not too much space there. And we'll compare. So hip looks similar, knee kind of looks similar. And honestly, I think your TFL on this side looks similar, maybe because you've been working on it. I would say that this is similar in flexibility to the left side. So it would be hard for us to pin your knee pain on just this. So let's move on by coming to sit up. Scoot back. You're sitting normal. I want you to slouch your head. I want you to slouch your upper back. And this is going to bowstring his whole nervous system through his spine. So as I straighten his knee, I put tension through his sciatic nerve and through his hamstring. Where do you feel that, Kirk?
Behind the knee.
Okay, and that's the same place you felt it when you bent forward, right? And that's a pretty normal spot for you to feel this. If you lift up your head, does it take it away at all?
Yeah.
So as he lets tension out of his spinal cord, the whole nervous system goes on slack and there's no sensitivity. But that's pretty mild, and you're a pretty flexible guy in that regard. If we do this side,
Tighter.
a little tighter, do you feel it in the same spot?
I feel it actually on the outside of my shin a little bit.
So you feel it, instead of in the back of your knee, it's kind of trending down into the lateral knee, lateral lower leg.
Mm-hmm.
If you lift up your head, does it take it away?
A little bit, yeah.
Still there, but less. And then bring your head back down, does it come back again?
Mm-hmm.
Okay, so symptoms are a bit different on this side, which is our first clue that there may be a little bit of sensitivity in the nervous system on the right, playing into his knee pain. So we're going to kind of keep that in the back of our heads and move on. Before we do anything else, I'm going to look at your SI joint. If you put your feet on the ball, you get a little platform. Almost regardless of what kind of problem I'm looking for in the lower body, I'll look at the low back because the lumbar spine is the circuit breaker or the headwaters for everything that happens downstream. It's where all of the nerve input, power, sensation comes from. And it's also where all the sensation from your leg back up to your spine and into your brain has to pass through. So it's a very important part of the body to assess when you're looking at lower body problems. So if you sit up tall first, I'm going to get right on the back of your pelvis, and I want you to take your legs apart and bend forward as far as you can. Reach down on that ball. And I'm looking for symmetry, and he has it. Come on, back up.
Yeah.
So you're very symmetrical in that regard. We can kind of check that box and move on. We're going to continue with our examination. Now with Kirk lying down, I'm going to continue testing his flexibility, his stability, and which muscles are activating well and which ones aren't. And again, more about how his spine is moving and may or may not be involved in his knee condition, in addition to poking and prodding. So let's start with you on your back, face up. Let's start from the bottom, Kirk, and I want you to pull your feet to your shins. I already kind of know your ankles are mobile because I watched you squat, but I like to kind of get a sense for how flexible you are. A little stiffer on this side, so I'm going to file that away, maybe come back to that. I'm going to take your leg and I'm going to bring it up. This is called the straight leg raise test, and this also looks at the sensitivity of your sciatic nerve. So where do you feel sensitivity, tension when I bring you up here?
Behind my knee.
Behind the knee. Okay, so I bring it across. Does it stay the same?
Yes.
Doesn't provoke your symptoms at all?
A little bit.
A little bit on this lateral side here where your pain is. If I release your foot, does it go away?
Yeah.
And as I bring your foot back up, it comes back.
Yes.
And this is how we know it's probably more nerve mediated, because I can change the sensation at his knee by moving his foot up or down, or by moving his hip up or down. I'm going to check your hip rotation. External, internal. Any pain doing that?
Just a little tightness in the TFL when you go internal.
This way?
Yeah.
And you feel it up here in this muscle, which I mentioned earlier is at the top of the IT band.
Yep.
If I bring you up in flexion, no problem with that.
Nope.
It's pretty free.
Mm-hmm.
No discomfort in your hip.
No.
No problem with that. All right, can you hold your leg in this position? I'm going to pull you this way, and I want you to resist me as hard as you can, okay? I'm testing your ability to stabilize against hip external rotation. It's pretty good. Struggling a little bit. Does it hurt at all?
No.
Hold here. I'm going to push you this way.
Ah.
That's a little hard, huh?
Yeah.
Does that hurt at all?
No.
Where do you feel it? Where is it challenging? Is it your hip? Is it?
I think it's my hip.
Yeah. You want to have one more try? You
Sure.
get a second try. Second chance. Ready? Hold it. Just a little tough, huh?
Yeah, it's the hip.
Okay. Can you hold it up here? I'm going to pull you down. Don't let me pull it. Ready?
Okay.
Hold it. Hold it. Hold it. That's really hard for you, huh?
Yeah.
And where do you feel that?
Hip
when I do
flexor.
that? So it goes to that spot that you were feeling when you had to sort of gimp home that day.
Yeah.
That secondary spot where it moves to. Okay. So it's just a little dysfunction, a little shutdown. I wouldn't even call it weakness because I know you're not a deconditioned person. It's just more a little shutdown. The muscle has lost a little bit of power. Let's do the same thing on the other side to compare. I'm going to bring this leg up. Let me know when you start to feel it.
No.
Similar feeling back in the knee?
Yeah.
As I bring it across, does it go to the lateral knee at all?
Yeah,
Outer
less
knee?
so.
Less so.
Yeah.
Okay, and that changes it a bit.
Yeah.
Okay, but similar pattern. It's
Mhm.
not too different flexibility-wise. Pretty similar range of motion-wise there in all regards. Can you hold your leg in that position? I'm going to pull you this way. Try to resist me. A little hard on that side too, right?
Yeah.
How about going this way?
Definitely
A
stronger.
little stronger there, and no discomfort
No.
up in your TFL, up in your hip. Yeah.
No.
So I wouldn't say those are shockingly different, but I think both sides maybe need a little bit of encouragement, a little bit of activation. Last one, hold here. Don't let me pull you down. Definitely stronger in that regard, right? In that side. Cool. Let's move on to look at your symmetry here. Can you bend your knees, do a little bridge, lift up your hips, and put them back down? And that just sets his hips even. So as I'm looking at things like the length of his legs, which I can check here, we have a nice even starting point. It's pretty close to me. I'm going to poke on your hips, Kirk. Might be a little ticklish. Use your hips as a reference. And I'm looking for symmetry of his bones and his pelvis on both sides, and things look pretty darn good there overall. This is called the Squish Test, and this is how I check for the mobility in his pelvis to see how even he is on both sides. Pretty even overall. And there's no discomfort as I do that, right?
No.
And then I can look at the height of his pelvis to see whether there are any rotations or other areas where he may be asymmetrical. And I really don't see anything of concern there. I'm going to move down to your knees, Kirk, and I'm going to sort of poke around on his kneecaps, make sure there's good mobility. I'm going to check to see how well he straightens, how well he bends. There's no pain doing any of that, right?
No.
I can take his knee through a few special tests in order to see if his meniscus is sensitive at all. Any discomfort with that?
No.
I kind of already knew that because I watched you squat and watched you move. I can check his ACL, and I can check his other ligaments to make sure they're all intact. Is it tender out here, Kirk?
No.
At all?
No.
So as his IT band comes down the side of his leg into his lower leg, I can sort of poke around and see if there's any sensitivity there. I can check right at the line of his joint, see if there's any sensitivity, lateral meniscus, no tenderness there at all.
No.
Okay, good. Same thing on this side, no sensitivity,
No.
right?
A little bit.
Sometimes it's interesting when people have pain in an area and it's not really tender to touch, but they still feel it. But you mentioned that it felt kind of deep,
Yeah.
like deep in there. And does that feel sensitive right at the joint line?
Right there, it does.
Right there?
Just a little bit.
This is closer to sort of your patellar tendon kneecap, but it's not excruciating, right? It's
No,
not
not
really
at all.
provoking your
No.
pain necessarily. So I'm
No.
going out of order, but I'm going to do some of these same tests. Check your meniscus, looking for creaking, popping, crepitus noise, not having any problem with that.
No. I feel like I'm guarding it a
Yeah,
little bit.
feel that a little bit, but it doesn't feel particularly
No.
sensitive. It's
No.
just more scary than anything.
Yeah.
ACL is there, always a good sign. When your ligaments are intact, I always like to see that. So really, surprisingly, not much sensitivity when I poke around, even though the pain can be pretty bad at times, right?
Yeah.
I'm going to check out both your IT bands. I'm going to kind of work my way up along the soft tissue to see how many trigger points you have. Some of you watching probably have done some rolling on your IT bands to try to smooth this out. Kirk, you've done some of that too, I assume. And
Yeah.
really, that tissue feels pretty clean, feels pretty healthy and loose coming down through there. If you contract your quad and you straighten your knee, relax. I can look at the timing of Kirk's quad and how well it's turning on. Can you turn it on, contract it, and relax, and turn it on again, and relax. I'm looking to make sure that this inner part of the quad is coming on at the same time, if not a split second sooner than the outer part of the quad. So it's doing its job of stabilizing his kneecap and hedging against the outer quad and the IT band kind of having their way with his kneecap and pulling it too far to the outside, which some of you have probably been told maybe that's happened to you in the past. Go ahead and give me one more contraction. Yeah, so nice contraction. He's got good development here, and I really don't see any problems with his quad. Go ahead and do the same thing on this side. Relax. Again, hold it. Yeah, pretty similar, pretty equivalent on both sides. Because of this high hip thing, Kirk, I'm going to come in, and you're going to not like me very much. The viewers might enjoy this. I'm going to come into your psoas, so I'm going to kind of come in deep to your abdomen,
Okay.
coming through his guts, so it's a little sensitive, but I want to get a sense for tissue quality and to see if this provokes some of this stuff up in the groin, okay? So I'm going to come through your abs as you breathe in, exhale. I'm going to work my way down in there. Is that tender?
Yeah.
Does it provoke pain at all?
No.
Okay, big breath. Exhale. And he's not really guarding. You don't feel like you're guarding, are you?
No.
But it has kind of a hard feel to it. It doesn't feel supple like some other parts of his body. A little guarded. He's making faces. I don't know if that's a good face or a bad face, but it's sensitive, right?
Yeah.
Yeah, and it's a little uncomfortable. So the psoas comes off the front of the spine, deep to the guts, and then comes down and attaches into the groin, right about here. Does that feel tender to you where it attaches?
Yeah, a little bit.
And is that the spot that you feel
When it locks up.
when it locks up on you?
Yeah.
So you get a little bit of that, huh? So, now I'm thinking like I need to make sure for definitely that I look at his back because that's where the psoas muscle originates. Contrary to popular opinion, the psoas is not really a hip flexor. It's more of a lumbar stabilizer, core stabilizer, and it also helps control movement quality at the hip joint. But it doesn't really have a great ability to actually flex the hip up. That's more the job of the quad, the long quad, and a few other muscles. But it still has a very important role in running from a stability standpoint. So let's compare that to the other side. Sorry. Gotta do it. Gotta do it. Take a breath in, exhale. No funny faces, not a lot of tenderness, not a lot of sensitivity.
Not bad.
Good. And that tissue feels pretty healthy to me. So as tendon,
Way less sensitive.
way less sensitive. So of everything we've looked at, this is kind of one of the more asymmetrical things, right? That
Yeah.
we've seen so far?
Yeah.
Cool. Bring that back down. I think I'm done in this position, Kirk.
Cool.
Let's flip over to your stomach.
Okay.
Face down in the face cradle, and let me look at your back. So in this position, I'm going to be spending a little more time looking at his back, strength testing some of his glutes and hamstrings to see how they're functioning. First thing I'm going to do is look at the symmetry of his pelvis. And he's looking pretty good there. I'm going to start at his sacrum, which is like his tailbone down at the bottom. Look at how symmetrical he is by how deep my thumbs are as I work up through his lumbar vertebrae to see if there's any rotation. He's just a little bit rotated to the left side. If you remember when I was watching him move before, there was one way he rotated a little bit further than the other. Come on up to your elbows, prop up into extension. You might not be able to see this, I'm sorry, but I'm basically looking at the same landmarks that I was looking at a second ago, with him now in extension. And I'm feeling for tension in his back, but I'm also looking for how symmetrically he moves. Come on up to your hands and knees. Sit back to your heels into child's pose. And again, if you can't see this well, I'm basically looking at the exact same landmarks again, but now in forward bending. And this gives me a sense for how well his spine moves in these different positions. I can tell in this position that he's a little stiffer on the right side. This right side of his spine, side of his symptoms, doesn't bend forward as far as the left side does. That's probably one of the more asymmetrical things I've seen in your spine. There's also, I can see more muscle tension on this side, which is very common when you have a very sensitive or dysfunctional psoas on that side. So that's consistent with the pattern. Let's go face down again. I'm going to take a look at your mid-back here, maybe bring your arms off the side and just kind of see how stiff you are in here, Kirk. You won't be able to hear this, but we get a few clicks and pops as I work down through his spine. Just to assess mobility there generally. Doesn't feel like too big a deal. As I poke into your back, Kirk, I'm going to bring this up so people can see a little better. As I poke into your back, does that feel tender to you at all?
Not particularly.
Okay, so I'm looking for tissue quality, I'm looking for density, I'm looking for how fascially stiff he is. I can even pull in the skin and give it a little tug and see how supple the soft tissue is in this part of the body. I'm not being very gentle with you, am I? Sorry.
It's all good.
And then the right side, because I said that there was a little more muscle tension, there might be some more muscle sensitivity. What do you think? Definitely a little more tenderness on this right side.
That's right.
Especially down here by his pelvis.
Yeah.
Just a little bit more. And he's saying it's tender, but I also feel a little more density. As I work down into his glutes, his hip muscles, upper, does it feel different to you at all?
Right's a little more sensitive.
Okay. Feels pretty healthy to me overall. As I work down into these hip rotators, these are the ones I strength tested earlier that were a little hard for him. Does that feel tender to you at all, Kirk? Left
My
right?
right side just feels like denser.
The right side feels
like
denser.
It just feels like I need to massage it.
Okay. Yeah, okay.
That makes sense.
Yeah, absolutely. And it doesn't feel too different to me, but we know that those muscles maybe are a little inhibited again. Not weak per se, but a little bit shut down on that right side. Maybe because of pain, maybe because of dysfunction. It's kind of hard to say. While you're here, let's test your hamstring strength. Can you bend your knee against my resistance as hard as you can on this side? Like you're doing a hamstring curl. Good. Go, go, go. Do it again. Go, 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 go. Any pain there?
No.
Hold here. Don't let me straighten it, okay? Hold it, hold it, hold it, hold it. Good. Any pain doing that?
Not really, no.
And Kirk said before he's been working on that, and that test's pretty strong. So good for you. Go ahead and bend this knee as hard as you can. Go, 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 go. Good. Similar. Hold there. Don't let me straighten it. Good. Relax. Any pain?
No.
You're almost stronger on this side, which is kind of funny because that's the symptomatic side. So again, we kind of rule out hamstring weakness as a possible contributor, I think, in this case. Let's go ahead and roll Kurt to your left side.
Onto my left?
Yeah, onto your left side. We're getting close to the finish line here. You're going to bring this leg up and back. This is how I test glute medius, which is an important running muscle. It's the muscle that's responsible for stabilizing your pelvis when you're on one leg, like you were earlier during your single leg squat. So this is what I'm going to get to see how well this muscle is firing. So hold your leg up in the air and don't let me push you down, okay? Hold that there. Ready? Begin. Second try. Ready? Hold it there. Come on, Kurt. Okay, hard to do. Does that hurt at all?
No.
Okay, hard to do on that side. Let's flip to your other side. Same test. Bring the leg up and back. Hold it up in the air. Don't let me push it down. Ready? Good. Definitely better on that side. Hold it there. Come on. The second time you did even better. So huge difference, right, between those two sides. For sure. Flip to your back one more time.
Okay.
Bring this up. I'm just going to poke on his muscle here. This is the TFL muscle at the top of his IT band. I call it the pocket muscle because it's like if you stuck your hand in your pocket, that's where it would be. Does that feel tender?
Yeah.
So this is his symptomatic side. This is the side of knee pain. This is the muscle I talked about earlier where it didn't look particularly short, but as I'm poking on it, it's very sensitive.
Yeah.
And because it has an effect and a role in stabilizing the lateral knee, the outer knee, through the IT band, if there's dysfunction there, it's not a big stretch to imagine that that would affect your knee on that side.
Makes sense.
So let's compare it to this side. It almost feels meatier on this side. Is it as tender?
No.
Not as tender, and probably a little bit stronger. And if you remember, this is the one that tested a little bit weak.
Yeah.
On this side, or not weak, sorry. This is the one that tested a little bit shut down on this side. So we definitely have a pattern that we're seeing, and while there are other things I could certainly look at, let's take a second to kind of get our heads around this, and then we'll see in a second, and we'll talk about not only how this fits, this pattern, and how it might be contributing to his knee pain, but what we're going to do about it.
Cool. All right, so that is what it's like to be in the PT's office. Thank you, Charlie, for joining us.
Good times.
Like I said, this is one part of a 3-part series, so if you missed the other videos, be sure to go check those out because it is a big process that is part of your relationship with your PT. It's not just them doing stuff to you. You have to be really good about telling them everything they need to know and being honest and bringing them the right information so that you guys can fix it together.
It's a process of discovery.
Yeah.
Team effort.
Team effort. And as Charlie mentioned, what was the big thing about pain?
Pain is not scary. Pain is a message from your body saying, pay attention, something's not right. So take care of it quickly.
Yes, the world is not over. There's solutions
right.
to all your problems, no matter how long they've been there. So if you missed the other parts, go check them out. If you like this video, let us know by clicking the like button below. If you have questions for Charlie or I, let me know by hitting us up in the comments. And Run Experience has a ton of crap on there, so be sure to hit the subscribe button to get updates on all the new videos and content coming out. We will see you guys in the next episode.
Sorry I hurt you, man.